This conference will now be recorded.
So today we are going to discuss about acute pancreatitis, one of the common emergency which you will encounter in an emergency room. So coming to our class, first we will discuss the basic anatomy and etiology of acute pancreatitis, and then of pathophysiology and clinical approach, how you need to approach a case in case of emergency room, and what are all the differential diagnosis available. This is one of the important questions for you. And assessment of severity and how to manage. Depending upon the time available, we will discuss all these things. So coming to the anatomy of the pancreas, one of the most important organ, which is situated in the retroperitoneum. So, the typical nature of its location protects it from various injuries and also makes it very difficult for us to approach surgically. One of the most complex surgeries involved in surgical community involves surgery of the pancreas. Now, in case of acute pancreatitis, it's more of a medical management, and in chronic pancreatitis, surgery definitely plays a major role. So, in the next class, we will discuss about chronic pancreatitis, and today we will discuss about. So, the retroperitoneal organ, which is situated in the celiac of the duodenum. If you briefly go back to your anatomy class, roughly D1, which is the transverse part, and D2, which is the descending part, and after that D3 and D4. So, pancreas is situated in the celiac of the duodenum. It has three portions: one is head, body, and tail, and another is extension of the head, which is known as uncinate process. Head, neck, uncinate, body, and tail. So this is the typical anatomy of pancreas, which is situated in the retroperitoneum. Posterior are the major vessels, inferior vena cava and aorta. Behind the neck of the pancreas, if you take a look at this in this picture clearly, you could appreciate behind the neck of the pancreas the splenic vein, and the superior mesenteric vein, which join together to form the portal vein, portal circulation. So this particular anatomical relationship is important when we operate a case in case of pancreatic head malignancies and periampullary case. This we will perform a Whipple surgery. In Whipple surgery, this particular relation is very important, and separation of the neck of the pancreas from the anterior part of the portal vein indicates the resectability of malignancy. So it is situated close to the kidney within the C loop of the duodenum, just like here. If you take a look at the cursor, here it will be C loop of the duodenum. It is like slightly directed towards the left upper quadrant. It is basically a little oblique in position. So the blood supply comes from the pancreatoduodenal artery, branches of gastroduodenal arteries. There are posterior, superior, anterior, and inferior and superior pancreaticoduodenal arteries. So basically, there are four. Tail, to some extent, it is supplied by the splenic artery, which runs close to its tails. So, in case of a tail injury, in case of splenectomy and all, one of the complications is injury to the tail can precipitate pancreatitis. So, the blood supply includes the pancreaticoduodenal artery. There are superior pancreaticoduodenal, anterosuperior, anteroinferior pancreaticoduodenal artery. Similarly, posterosuperior and inferior pancreaticodental artery. All of these they are anastomosed together to form collaterals. So just if you take a look at in this picture, just like in C shape, it is situated in the C loop of the duodenum in the retroperitoneum. So coming to ductal drainage, the main duct is pancreatic duct of Wilson. One more thing we need to appreciate is pancreas arises from two buds, namely the dorsal bud and the ventral bud. Ventral bud arises from the hepatopancreatic duct, and dorsal bud is located posterior towards mesentery. So the ventral duct migrates posteriorly, and which forms the inferior part of the head and uncinate process. So proximal part of the head, neck, body, and tail is formed from the dorsal bud. So the ductal drainage of both these are also similar. So most of the pancreas is drained by the duct of Wilson. So the ventral duct, the distal part together with the duct of the dorsal bud together to form the duct of Wilson. In some cases, the proximal part of the, roughly in about 20% of the cases, the proximal part of the ventral duct, it may remain separately and it may drain into the minor papilla. This is called as the axillary duct of Santorini, which is seen in roughly 20% of the cases. The main duct is duct of Wilson. So axillary duct, it drains into the minor papilla, and main duct of Santorini drains into the major papilla. If you open, there will be a T-shaped location, T-shaped appearance of drainage in case of a major pancreaticodental papilla. So, gastrodental artery, which gives rise to superior, anterosuperior, and posterosuperior pancreaticodental arteries. Along with this inferior pancreaticodental artery, which is the first branch of the superior mesenteric artery. Superior mesenteric artery gives rise to inferior pancreaticodental artery, which has corresponding anterior and posterior branches. These anterior and posterior branches of the inferior pancreaticodental artery, they form a network with the anterior and posterior branches of the superior pancreaticodental artery, which arise from the gastrodental artery. These are the major branches which are supplying in the pancreas, and together with, there is also some transverse pancreatic artery, and also splenic artery supplies the distal part. So transverse pancreatic artery could arise from splenic artery. If you take a look in this picture clearly, this is a major duct, which is major duct drains into the major duct of Wilson drains into the major duodenal papilla, and the axillary duct, which is in roughly 20% of the cases, drains into the minor duodenal papilla, which is known as the duct of Santorini. So in histology, you need to remember the pancreatic duct and the highlights and SNS structures, and both exocrine and endocrine functions. Endocrine, there are most important of them is insulin, glucagon, and somatostatin and all. Coming to the exocrine portion, it helps in the release of so many enzymes which are helpful in digestion of fat. These enzymes are released into the small intestine, which helps in the digestion of various components of diet. So this image you could clearly see superior pancreaticodental artery, which is corresponding anterior and posterior branches, which are from the gastroduodenal artery, which is a branch of common hepatic artery. Superior mesenteric artery directly gives rise to a branch of inferior pancreaticodental artery, which is anterior and posterior. So pancreatitis inflammation of the pancreas. So it is divided into acute and chronic. So there are various discriminating points between acute and chronic pancreatitis. Chronic pancreatitis is mostly based upon histological features and irreversible fibrosis, which is accompanying multiple episodes of acute pancreatitis can give rise to chronic pancreatitis. So in case of acute pancreatitis, because of the inflammation, it presents with severe abdominal pain, which is associated with the rise of pancreatic enzymes. So the typical classical sign is the pain in the abdomen epigastrium, which radiates to the back. So this incidence is roughly 3% of the cases. So it can occur at any age, with peak in young men and old women. In young men, mostly it's due to alcohol intake, and in older women, it's due to gallstones. So one of the major causes, one is alcohol abuse, and the most common cause is biliary cholangitis. So this table summarizes different causes of acute pancreatitis. The most common is the gallstones. Second most common, the alcoholism, and post endoscopic retrograde cholangiopancreatography. Because of this, a complication of the procedure, it can be seen in roughly about 2 to 3% of the cases, and in abdominal trauma following any surgery in the region of pancreas, like biliary, upper gastrointestinal, and cardiothoracic surgeries. So it is also a feature of ampullary tumors.
Hey,
So there are some.
వచ్చి దేరుతావు పెట్టి గిన్నెలో పెట్టామ్మా.
There are some drugs which side effects of drugs is chronic acute pancreatitis, like corticosteroid surgery, azathioprine, asparaginase,
అది గిన్నెలో పెట్టుకో, గిన్నెలో పెట్టేయాలి.
hyperparathyroidism and hypercalcemia. Pancreatitis means the dorsal and ventral, but they fail to fuse and they drain separately. Autoimmune pancreatitis, it is associated with other autoimmune causes, and hereditary pancreatitis because of some mutations and so viral infections like coccidiosis and mumps virus, malnutrition, scorpion bite, and if no etiological factor is seen after ruling out all of these causes, then it is termed as idiopathic. So this is a mnemonic for various causes. Acute pancreatitis, I get smashed. So I means idiopathic, G gallstone, which is the most common cause, E for ethanol, alcohol, second most common cause, and T for trauma, mostly seen in blunt trauma episodes. Pancreas is relatively protected by its location. So in severe injuries, it could get affected, and medications like steroids and all. Mumps and malignancies, autoimmune and scorpion bite, hypercalcemia, hypertriglyceridemia, and hyperparathyroidism. E as a complication of ERCP. D for drugs. So gallstone pancreatitis is one of the most common cause of so gallstone pancreatitis. The pathophysiology involved is transient blockage of the pancreatic duct together with the biliary duct, both together from the hepatopancreatic ampulla of water, which drains in a common channel. Depending upon the length of the common channel, there could be various effects like anomalous pancreaticobiliary junction and all. So a lodging and blockage of common bile duct. So common hepatopancreatic duct secondary to the gallstones can lead to a rise in intraductal pressure, which is this rise in intraductal pressure and subsequent intraductal hypertension can impair the flow of pancreatic juice, and which can lead to stasis, and this stasis of the pancreatic juice calls in for premature activation of the pancreatic enzymes. So alcohol pancreatitis is the highest thing in long-standing alcohol intake for at least 2 years, or in case of heavy binge drinking. So alcohol can cause direct toxic, which in case of it is more The effects are more severe in case of genetically predisposed individuals. So the visceral secretion of pancreatic juice causes formation of protein plaques, and then impairment of pancreatic juice flow could result in pancreatitis. So the most common the common pathway involves the premature activation of preformed enzymes within the pancreas, which leads to the process of autodigestion. Trypsin, which gets activated, leads to catalytic chain of events, and which can lead to activation of all other enzymes, lead to the process of autodigestion. So this helps. This mechanism induces the inertial and the secretion of zymogen granules. So after the cellular injury has been initiated, there will be a sequence of inflammation leading to edema, hemorrhage, and finally in necrotic. So because of the release of inflammatory mediators into the circulation, systemic complications can arise. So common causes, if you know, most common early because of three main reasons. One is the duct obstruction, just like in biliary calculus, lodging in case of hepatopancreatic ampulla, and direct descendant cell injury secondary to alcohol, drugs, and trauma. And because of defective intracellular transport, metabolic age, and duct obstruction, all of these lead to interstitial edema and premature activation of release of various proenzymes and lysosomal hydrolysases. So all this leads to intracellular activation of enzymes, finally culminating in acinar cell injury. Secondary to inflammation, because of this activated enzymes, there is interstitial inflammation edema. So proteases cause proteolysis and fat necrosis, lipase and phospholipase. Elastase causes dissolves the wall of the vessel supplying and leads to hemorrhage. So in case of serum, coming to the history and the physical examination. So purpose of history taking is to rule out to understand the mechanism and to know the etiological factors and to come to a diagnosis provisional. So we need to ask about the nature and severity of the pain and any accompanying features. So causes and complications. So abdominal pain. This mnemonic, which you might have clearly come across in case of clinical presentations in the ward. Socrates means site. First one is site. Pain site of in case of pancreatitis, it is most commonly it is severe pain in the upper abdomen. O means onset. Onset is sudden. Character is boring type of pain. R means radiation. So this is located properatonym. The pain radiates to the back. Associated factor could be nausea and vomiting could be associated. So timing pain escalates within 10 to 20 minutes of the onset. So aggravating factors and relieving aggravating factors and it is aggravated by breathing, increased because of increased chest expansion, and it is relieved by leaning forward. This sign is known as Muhammadan prayer sign, just like Muslim people's prayer where they lean forward. Similarly, that type of leaning forward position helps in relieving the pain in case of acute pancreatitis. So the sign is known as Muhammadan prayer sign. Depending upon the inflammatory process, severity, in severe cases, the patient may present in shock and also be the pathology can progress to SIDS and MODS, systemic inflammatory response syndrome, and dysfunction syndrome. So, history of the underlying process, we already came across this pneumonia. You need to ask the patient about the history of any biliary pain and alcohol intake, whether there is any trauma. So, medication history to rule out steroids, and and all other medications which contribute to acute pancreatitis, infection, mumps and Cossacks virus, scorpion bite, hyperlipidemia. In case of ERCP, it is equal to the procedure. So, history of complications. Rapid progression of the symptoms could lead to ARD, respiratory distress syndrome, renal failure, shock, and arrhythmias. Metabolically, to hypocalcemia and hyperglycemia and encephalopathy. Depending upon the various organs involved, kidneys may get involved leading to renal failure, and later in the course of the disease, it could involve multiple organs. So local, mostly they silently, local complications, pancreatic abscess, there is secondary infection of the necrotizing material, it will lead to pancreatic abscess, which presents as a high-grade severe fever, which is not responding to the medication. And pseudocyst means it is not lined by an epithelial wall. So there are two types of complications for in acute pancreatitis. One is acute fluid collection, and the other is pseudocyst and pancreatic effusion or pancreatic ascites. Coming to the physical examination, elevation of body pressure because of release of inflammatory mediators into the circulation. Patient will be febrile. On abdominal examination, it will be abdominal distension, and there will be decrease in the movement of abdominal wall with respiration because of the underlying inflammatory processes. Coming to palpation, this would be the hepatomegaly tenderness and fuse tenderness in the location. Pathology and the important signs, cleanse and greaterness signs, periumbilical ecchymosis and flank ecchymosis. There is also Weil-Gel sign, which is ecchymosis of the upper thigh, and there is Fox sign, Cullen greaterness, Weil-Gel sign, and Fox sign are the signs of various ecchymosis, ecchymotic signs in case of pancreatitis. Other respiratory signs depending upon severity, rigidity, and guarding. Periumbilical ecchymosis is Cullen sign. So flank ecchymosis is known as greaterness sign. So percussion, it could be dullness, pancreatic ascites. Auscultation is to assess the abdomen for hyperactive or hyperactive bowel sound. Because of pancreatitis, there could be local ileus, which could result in absent bowel sounds. Auscultation of the lung, there could be pancreatic effusion. So most commonly left side findings are common. Basilar rails, like this, and communication can pleural effusion. One of the another rare complications is pancreatic pleural fistula. So coming to the differential diagnosis and investigations to confirm your diagnosis and severity to the grades, severity of the patient and plan a treatment accordingly. There are various scoring systems available. So mild and acute pain, the differential diagnosis include anatomically the organs located close to pancreas. One is acute polycystitis, peptic ulcer disease, and inferior or myocardial infarction, and acute appendicitis. So for severe acute pain, it may be due to fecal peritonitis or ruptured abdominal aortic aneurysm, which is a catastrophe. And in case of females who are in the fertile group, one of the important differential diagnosis which you need to look is ruptured ectopic pregnancy. So any patient, any reproductive age group female coming to the casualty, you need to ask about last menstrual period and rule out whether she is pregnant or not. And in rare cases, massive bowel infarction, which is an abdominal catastrophe. So How will you investigate the patient and confirm the diagnosis? Investigations. The classical clinical picture coupled with raised pancreatic enzyme levels is suggestive of acute pancreatitis. You need to measure one is serum amylase and lipase. Amylase, coming to the both of these, serum lipase is more specific. Serum amylase, it increases fastly and comes down very fastly. So early in the course of disease, serum amylase increases 3 times the normal value, or roughly more than 1000 is confirmatory. 3 to 5 times more normal value is suggestive of acute pancreatitis. The problem with serum amylase investigation is it will be raised in other causes, other abdominal pathologies also, like perforation, intestinal perforation, hollow viscous perforation, obstruction, renal failure, and all. In these conditions also serum amylase can rise. So rise in serum amylase is not specific. And serum lipase has longer life, so more useful in delayed cases. Lipase is more specific pancreatitis than amylase. So renal failure, liver cirrhosis, hollow viscous perforation, inflammation of GIT, and rupture of ectopic pregnancy and salpingitis. So salivary gland inflammation like hepatitis. All these conditions can cause increased serum amylase. Salivary amylase is different from pancreatic amylase. So other blood tests which you need to do is one is full blood count, LFT, blood urea nitrogen, random blood sugar, serum calcium. So full blood count, in case of a secondary infection and all, there would be rise in WBC levels. So elevated leukocytes, it is a component of Rankin's criterion to predict prognosis. LFT is the cause of pancreatitis or fructogenitis. Blood urea nitrogen, one important component in the treatment of pancreatitis. This is decreasing pain suppression and adequate rehydration of the body. The patient will be severely dehydrated, leading to increase in nitrogen values. So random blood glucose versus so beta cells damage in pancreas interferes with insulin production, causes hyperglycemia. Serum calcium, hypocalcemia means saponification. So imaging role. Imaging, its role is to clarify diagnosis when the clinical picture clearly can't separate other emergency diagnosis. So to determine the possible causes. So in case of to assess the severity, there is a grading in CT scoring system known as Valset CT severity index, and to detect complications also. So how to determine the possible causes? Suppose in case of ultrasound, you clearly look at gallbladder and associated gallstones and all. So the most common investigation which is used in emergency room is ultrasound. So transabdominal ultrasound, it does not establish the diagnosis. It should be done to rule out other conditions. So coming to the causative factors, it can detect the gallstones. It can rule out acute cholecystitis depending upon the wall thickness and perigallbladder inflammatory changes in the very cholestatic fluid collections and all. So ultrasound can also determine whether the common bile duct is dilated or not, and to evaluate the changes in pancreas edema. So roughly in case of pancreatitis, the ultrasound report of the radiologist will give us pancreas is bulky and edematous and all. If there are any secondary changes like complications like pancreatic ascites or any localized fluid collection, it can be seen. Cortisol also can be appreciated, but necrosis is better seen with CT. So this transfers a transabdominal ultrasound. So there will be ill-defined heterogeneous and hypoechoic pattern. In the scan, if it is too white means it is hyperechoic, and if it is dark in texture, then it is known as hypoechoic. So ERCP could be diagnosed and therapeutic, and in cases of one thing, it is a double-edged sword. Post ERCP also 2 to 3% of the patients they get acute pancreatitis. So one is to look for gallstones and the CVD stones, and if there is any obstructive pathology, it could be therapeutic like performing a sphincter and promoting the drainage of the biliary rectum. In severe acute gallstone pancreatitis, the obstruction and cholangitis and urgent but in these cases the urgent ERCP is to decompress the biliary tree and combat cholangitis. This is a normal image. This is endoscopic retrograde cholangiopancreatopathy. So for cannulating cannulating the middle ampulla pattern and opening of the duct at the major duodenal papilla, the dye is injected. So as a dye, you are injecting dye from retrograde from its opening to its starting position. It is known as a retrograde cholangiopancreatopathy. This image is sized of normal binding defect. In case of moderate pancreatitis, there could be dilatation of the pancreatitis. In severe cases, could be dilatation and some calcium foci can be seen in the duct like pancreatic stones. So coming to plain abdominal X-ray, it is commonly undertaken but rarely confirms the diagnosis. In severe case of calcium pancreatitis and stones in the pancreatic duct, we could appreciate it. So there are few non-specific findings which you need to. One is the local alias, sentinel loop, and the colon cutoff signs. If there is any gallstone, which is pretty good, appreciate it in plain abdominal X-ray. So direct chest X-ray, it is to rule out pleural effusion in severe cases, and in the very severe cases, the diffuse alveolar dying because of acute respiratory distress syndrome. This is sentinel loop, a focal dilated small bowel loop in the left upper quadrant because of inflammation surrounding the inflammation in the pancreatic region. So this focal adenemic alias, it may the location of dilated bowel loop can help in diagnosis. Whereas if there are small bowel loop dilated is in the right lower quadrant, it is due to appendicitis. And sentinel loop in the upper abdomen. These are the non-specific findings in case of abdominal X-ray and colon cutoff sign. Colon sign means gaseous distension in case of proximal colon, filled with a narrowing of splenic flexure. So this appearance is seen in case of improvement process extending from pancreas to the phrenecocholic ligaments where the transfer from the colon. So CT scan is not necessary for all patients. It may reveal various complications and helps in identification of the etiology. So contrast enhanced CT scan is a gold standard for diagnosing pancreatitis, and it it should be taken roughly after 72 hours. In early case, and patients who present early to the emergency department, the CT scan is of minimal use. For the findings to be well appreciated, it roughly takes about 72 hours. So, contraction and CT scan taken after 72 hours is the gold standard. So, there is diagnostic uncertainty in severe acute pancreatitis, and also to rule out necrosis, signs of sepsis and progressive deterioration, and complications like pancreatitis and cirrhosis and all. So this is a CT scan image showing dilated pancreas with splenoportal veins and aorta and vena cava. This is anteroposteriorly, if you clearly appreciate. These are the muscle layers, and this is a cut section, and these are vertebrae. This is anterior, and this is posterior, at the level of epidural aorta, inferior vena cava, splenic vein combines with the superior mesenteric vein, the portal vein, dilated pancreas. So, CT scan findings suggest to include significant swelling and inflammation of the pancreas. So there are various types of classifications of acute pancreatitis. One is the Atlanta classification, which is most commonly followed. In Atlanta classification, there are two types of pancreatitis graded into two types. One is the interstitial edematous, and the other is necrotizing pancreatitis. Necrotizing pancreatitis, the parenchymal necrosis or peripancreatic necrosis of the combined type. Interstitial edematous is only seen in case of gallstones, and necrotizing pancreatitis is seen in case of alcoholism. So interstitial edematous means because of reactive edema, the pancreatic parenchyma shows a homogeneous enhancement and the peripancreatic fat standing. So this is relatively, it has better outcomes. So in 1 week to 10 days, the symptoms usually resolve. So necrotizing pancreatitis is a severe complication. Air within the cavity of the pancreas leads to necrosis. So acute necrosis. This is a case of a 47-year-old woman presenting with necrotizing pancreatitis. This arrow clearly suggests a newly developed heterogeneous collection in pancreas. So this heterogeneous collection, it is confined to the pancreas. It does not extend beyond the peripancreatic tissue. So gas in the collection is a history of necrosis. So it is due to impairment of pancreatic perfusion. So the impairment evolves over several days. Early CECT. So this thing, early CECT may underestimate the disease. So the contrast enhanced CT scan is typically taken after 72 hours. So revised Atlanta, the fluid collections are two types. One is the interstitial pancreatitis and the necrotizing pancreatitis. One is less than 4 weeks. So it leads to acute peripancreatic fluid collection. If it is more than 4 weeks and confined by the collection is confined by the facial planes and surrounding organs, it results in pseudocyst. The pseudocyst doesn't have a epithelial layer, so hence it is epithelial lining layer. So it's the wall, so it is known as pseudocyst. In necrotizing pancreatitis, it is less than 4 weeks. Acute necrotic collection, if it is more than 4 weeks, then it is known as walled up necrosis. So pancreatic fluid collection, the revised Atlanta guidelines shows acute peripancreatic fluid collection, pancreatic pseudocyst, acute necrotic collection, and walled up necrosis. So you need to suspect local complications. that is persistence or recurrence of abdominal pain and increase in serum pancreas activity, increasing organ function, septic complications like increased fever and leukocytosis. Prompt C contrast and hence ECG to be done in these cases.